Okay, sounds like from Margie, everybody's here. Well, I just want to very briefly introduce yet another great webinar put on by really the association and all the committee members who really are doing all the work to make this happen. This is a webinar put on by the Junior Surgeons Committee, run specifically by what I like to call the Tims, Tim Newhook and Tim Vreeland, who have done an amazing job really raising the bar for the junior members and for everybody else to really provide as much guidance and help as we can. And I think this webinar will really go even further to do that. And I also want to mention Dr. Morgan Bonds, who I think helped put this together as well. It's an amazingly important topic that's really addressing, I think, all the anxiety that goes around starting a new career in HPB when you get out there and you're a little anxious about your technical skills, your clinical skills, your ability to develop an academic career, and how you utilize all the people around you. We have an amazing lineup, and I'll let Tim Newhook introduce everybody, but it's really a pleasure to get this going, and I'm excited to hear the talks. Thanks, Tim.
Thank you very much, Dr. D'Angelica, and thank you all for being here today. Obviously, welcome everyone, and thank you to our first webinar brought to you on behalf of the Junior Surgeon Committee of the HPB, as Dr. D'Angelica mentioned. As I said, this is our first, and we're a relatively new committee focused on engagement, involvement, mentorship, and education for aspiring and established HPB surgeons within the first 5 years of practice. We certainly would like to thank the HPBA, including our president, obviously, Dr. D'Angelica, who just spoke, and our past president, Dr. Pollack, for their unwavering and continued support in getting this committee off the ground for y'all. And it has really been incredible. I'm going to share my screen here just to bring up our topics for today. We have a very impressive set of speakers here today, and we'll try to follow along to keep us on schedule. We're going to ask questions primarily at the end, except for Dr. Minter. But today we're discussing strategies for success as an early career HPB surgeon, a practical clinical toolkit. And as I said, hopefully we gain some true pearls on a variety of clinically relevant topics for junior HPB surgeons from these leaders in the field. Just to introduce myself, I'm Tim Newhook. I'm in my second year of practice as an HPB surgeon at MD Anderson here in Houston. And I personally have derived tremendous inspiration and education from the HPBA beginning as an intern. And our goal as a committee is for you to get the same sort of experience. Co-moderating with us today is Dr. Tim Vreeland, who's an HPB surgical oncologist at Brooke Army Medical Center in San Antonio, and Dr. Morgan Bonds, who's an HPB surgeon at the Oklahoma University Health Stevenson Cancer Center. So here's just to go through the members of the Junior Surgeon Committee who Tim, Morgan, and I are just representing today, but this has been an incredibly excellent, devoted group of individuals from a diverse set of practices, regions in the Americas, and I've been very eager to bring these initiatives to junior surgeons within the HPBA. So thank you. So with that, Dr. Bonds, take it away.
All right, thank you very much, Dr. Newhook. So it is my pleasure to introduce our first speaker, Dr. Rebecca Minter, who is our former president of the America's Hepatopancreaticobiliary Association and the chair of surgery at the University of Wisconsin. Today, she's going to tell us what in the initial years of a practice as an HPB surgeon, what our bosses want. Dr. Minter, thank you for joining us.
Thank you so much, Dr. Bonds. This is always the hardest part, is sharing one screen, or the correct screen, I should say. Okay. Are you able to see my slides? Okay, perfect. Great. Well, a huge thank you to Drs. Vreeland, Dr. Newhook, Dr. Bonds, all of the junior surgeons committee. It made me reflect when I heard your name of thinking back to when my senior partner, when I was at the University of Michigan, always referred to me as her junior colleague, and it used to drive me crazy, but now I wish for the days when someone would call me junior. So I've completely rethought that term. So I have no relevant financial disclosures, sadly. I do want to disclose that this is just one boss's opinion, right? So some of what we're going to talk about today is really understanding what your boss wants, because we're all different in what we want, but there are certainly some themes and parallels. So of course, everybody says RVUs, right? You just want me to be an RVU generator. And while HPB surgery does generate a lot of RVUs, that is not the sole purpose of your existence, no matter what people tell you. So we talk way too much about RVUs. They're easy for the bean counters to count. They are useful at a high level in terms of understanding what's happening in the department or your practice in terms of productivity. But at an individual level, this is not the primary thing that your bosses want from you. So most importantly, I would say is don't try to be a mind reader. All of us try to be mind readers, and all of us are really terrible at being mind readers. So really, the most important first message I have to all of you is just ask. This should not be a mystery. If you are taking on a new job with your partners, however you define your boss, we all have multiple bosses, by the way. There's never one boss, right? We have multiple bosses that we need to please at some level. And really important to just ask, make sure that there's alignment between what your understanding is of what your goals are and what you're supposed to deliver to the department, to the hospital, to the institution, and what your understanding of that is. You want to make sure that your understanding and their understanding are aligned. And if they're not, then that's a really important thing to talk about. But too often I find this conversation doesn't actually happen, and everybody is having a different narrative, a different story in their head. And when you have those misaligned goals, then it's not surprising that you have mismatched expectations. So first and foremost, if you're in the process of looking at jobs straight out of fellowship, or you're in a job, then you need to just ask. And sometimes your bosses change, right? Sometimes you're recruited by one person and then a new person comes in and they might have a totally different idea about what you're supposed to do. So again, just ask, don't make assumptions, because usually when we make assumptions, we're usually wrong. So related to those mismatched expectations, how do you avoid that? And I see this happen far too often, and this is usually when folks are not happy. So the best way to avoid mismatched expectations is to really be clear first with yourself about what are your goals. And really you think about this in kind of 1, 3, and 5 year increments. These things are not set in stone. I'll say that we're also not very good at this coming right out of training. We've been on this hamster wheel. You are just worried, you're just going through the days, right? You're busy, busy, busy. You haven't actually been forced to pause and think about what your goals are for the next few years. You've just been showing up where you're supposed to and doing what you're supposed to do. So it is really critical to spend some time reflecting on this. Where would you like to be? What are you passionate about? How do you want to spend your time? What clinical programs do you hope to build? Obviously, everybody's first thought is, I just don't want to kill anyone and I don't want to hurt a patient, right? Especially with the types of operations that we do. And that's a great goal. But that's just part of your goals, right? Like you want to be a great surgeon, but there are other things. What are those other things? Spend some time reflecting on them. I find too often when people come and interview with me, they are just trying to be so accommodating. I'll do anything. I'll do this. I'll do that. I'm left with wondering what they really want to do. And I'm much more impressed if someone comes in and says, this is what I want to do. And then that allows me to say, okay, we can support you doing that here, or we can't, or we can support part of that, but here's the part we can't. I'd much rather have that kind of a conversation. So yes, you want to be accommodating to some point, but also be clear about where you're trying to go. Then once you're clear about that, you have to make sure there's alignment. I will tell everyone, as I tell all of our trainees and our young faculty, the most critical part of your first job is landing in the right place with the right people. People get really stuck on little things that don't matter quite so much. Yes, there has to be sufficient case volume to support your learning curve and your training, But at the end of the day, it's about culture and mentorship and support, and find the place that you really feel that, and that's the job you want to be in. You're taking a job, right? You're not like, it's not a life sentence. So if it's not perfect, you also can move on to the next opportunity. But try to find a place that's really going to support you and foster your development. And again, make sure there's alignment with what you want to do and what your boss thinks you're going to do, so you don't have those mismatched expectations. Think about how you can add value, and this can be in lots of different domains. What do they need? What is something that they would like for you to do? And sometimes it's nothing you actually would want to do. I will tell you, when I was a new faculty member at the University of Michigan, they needed somebody to be on the pharmacy and therapeutics committee at the VA. And let me tell you how awesome that committee was for a year and a half. But I did it. And I got a lot of positive credit for that, because it was a pain point for my boss at the time, who kept getting asked, which surgeon's going to be on the P&T committee, which surgeon's going to be on the P&T committee. And so by saying yes to that, it opened up other opportunities for me elsewhere. So think about, that's not how I added my value per se, but that was a valuable thing to do in terms of helping my boss out to make something less painful for her, so that then she created opportunities and was willing to help me later. If you can bring value in the training program, if you're in an academic program, if you can bring value in community outreach and going to a clinic that's a little further away that somebody else doesn't want to do, think about all of those things, understand what your boss needs or what pain points they're trying to solve, and be willing to lean in and bring value in those ways. Showing up, Woody Allen's exactly right, is 80% of it, and then lean in, as Sheryl Sandberg says. If you just show up and lean in and engage and be a good colleague and a good partner, you're going to be successful. That really is so critical and so important. And really, again, what your bosses want is not to be getting called about HR problems or interpersonal conflicts and issues that you have with other people, because that's probably the least fun part of our job, right? And so try to just be a good colleague and be really engaged and show up. When you show up, though, consider how you show up. And I would strongly encourage everyone to take a glass half full rather than a glass half empty sort of approach to life. And even if you tend to be a glass half empty sort of person in your personal life, try not to be that way at work. So try to come with a positive perspective on the world, even when things are not perfect. That is certainly much harder at the end of a global pandemic 2 years later for all of us, and something I have to remind myself of daily. But you will find that especially earlier in your career, this will have tremendous impact and will amplify the positive perspective that people have about you as you show up in this new environment. I would also say, as a boss, there's nothing more frustrating to me than somebody who is a victim all of the time. So that is not to say that sometimes there are not absolutely legitimate injustices that we need to address. And certainly if they relate to gender bias or racism or anything like that, then that is not being a victim. That is appropriately elevating an issue that needs to be addressed. However, sometimes people tend to show up and say, I'm not successful here because this person's in my way, and that barrier is there, and that barrier is there. And I find that to be personally exhausting. So I want to build a team of people who come and say, I want to tear down that wall, and they told me I couldn't do it. So I figured out 3 ways that we're going to move around that wall and build that program over there. That's an energizing and exciting to me, not breaking the rules, but figuring out how to move things forward and not being held back by all of the things that are holding you down. Don't be too rigid. There are many ways to do things, and look for solutions instead of all of the problems. So there absolutely are problems that need to be fixed, but approach them in a positive way and come with solutions. And really importantly, bosses don't like surprises. So if something happens that you feel like someone else is going to come tell me about it, please come tell me about it yourself first, because then I can be prepared, understand what happened, not be surprised. So that's, I think, I have faculty who come and I know they hate it, but they'll sit out and they'll knock on my door and say, I want to tell you about this case that happened that, didn't go as planned. And that doesn't happen every time, but if it's something that really is a significant departure from what should have happened, then that's a good thing to talk about. And if you have senior partners, that's a good thing to talk about with them. So 2 tools I will encourage all of you to use is humble inquiry and the 5 whys. So, assume best intent. When people come to you with things, assume that they're not out to get you, they're not trying to undercut you in some way, but really assume best intent. And if something seems really crazy and stupid, why do you do it this way here? Just ask why, So why is it that we, approach this particular way here? And what you'll find as you peel back the layers is there's either a good reason for it or there's a dumb reason for it that will become immediately visible to everyone. If you use questions as a way to clarify things rather than attacks, this will again serve you very well, both with your boss, but also with everyone else that you work with. Last couple comments I'll make, and this is an important one, is, remember to just be nice to people. Save your scalpel for the OR. And some days we're not nice. Don't forget about the power of an apology. Especially these days, people are so stressed. Everybody likes to report everybody and, send these complaints. That doesn't help with anything. So just remember to be nice to folks. This carries you a very long way. And if you have a bad interaction in the operating room or someplace else, just circle back and say, hey, I'm sorry. I was stressed, I was having a bad day, whatever it might be. I really apologize for showing up that way. And then it's just done and people move on. If you don't do that, it festers. People make up these stories about you in their head about what a terrible person you are and how rude you are. And you want to avoid that. If you are going to work with residents, do not let them sense your fear and make them your advocate. So residents are a powerful force in academics, and you want them to respect you, you want them to see you as a good teacher, and you want them to be your advocates. I cannot emphasize this enough. You really have to engage with the residents in a positive way and make them your colleagues and friends and advocates. And don't forget about that, because it is very hard to pivot to the left side of the table when you've been on the right for a long time. So this takes conscious effort to do this right. And when you fall down, as you will, even though that girl looks really creepy, get back on your horse, and please remember to always use your posse or your tribe or whatever you want to call it, but use your colleagues that will support you. We do big, hard, challenging things, and bad things will happen. And you just have to work through it, but then you have to get back in the OR, you have to keep going, or else you won't be able to take care of the next patient if you don't. So that is important your whole career, but especially the first 5 years. So with that, I will close, and thank you so much for the invitation. And I'm happy to take a few questions if there's time.
So we haven't gotten any questions in the chat. Do any of the moderators have a question for Dr. Minter?
Yeah, I could ask a question of Dr. Minter. Thank you very much for your time and those excellent pearls. Really appreciate it. Definitely align a lot of that with what my first couple of years so far, and appreciate it. I had 2 questions. I'll start with one and then maybe let other people have an opportunity. But how would you recommend, as a young HPB surgeon, and all of us have had similar but also diverse training, and there's a very important balance, I think, that at least I've felt, between independence and being showing that you're a safe surgeon and you're well trained and you're okay to be in practice on your own, but also knowing when to involve senior partners or your boss in complex situations to, in the end, continue to grow as a safe surgeon without going down a separate Y in the road that can lead to worse outcomes. Any tips to us about how to maybe engage without bothering our bosses and on our way to a safe surgeon, and how to create a team around us?
Well, first of all, you're never bothering us ever. And so I think that I would say more often, that's what I see is people don't call because they think they're bothering you. So I would just tell you again, if you join the right group, you are never bothering your colleagues when you call them for help. And I call my colleagues for help today when I'm in a tough case. So I think that that's not unique to being a junior surgeon. I think, ways to buffer that. I think the thing that comes to me the most is, gosh, so-and-so's taken a really long time to do this operation. OR time is difficult to get, or that robot case took 12 hours, or, those are the kinds of things that I would say come up. They were safe, the patient did fine, but, from a resource utilization standpoint, there's some concerns. So I think that, planning your case in advance, that mental rehearsal is huge, right? Before the case, talking about people with the case, how you're going to approach it. And then setting some kind of time limits for yourself, right? Like, especially if you're doing some complex MIS case, if you don't make this amount of progress by this amount of time, that you're either going to call for help or you're going to convert or whatever your action plan is going to be. Because it's really easy when you're in the OR in the moment to get sucked in and not realize, how many hours have gone by and you've made very little progress. So I think by, setting some milestones in the case for yourself in advance with some time parameters to at least pause and say, are we making progress or not, is probably the best thing that you can do. Of course, I think people always call when they really get into trouble or bleeding or what have you. But I think the more common scenario is just taking really, really a long time and not calling for someone to help you. When you call people to help you, you learn something, right? Like they set it up differently. They get out of whatever has you stuck, and then they leave and you keep going. So I would encourage everyone to call and not ever feel bad about that. And then the last comment I'll make is sometimes, and it's rare, there can be people though who lack confidence, who call too much. And I don't mean too much because they're bothering you, but they're not building their confidence. And so that's where, if your bosses are like, nope, you've got this, you'll be fine, I'll come check on you in a little while, that's them telling you, keep going. You're going to be okay. I don't need to come and look over your shoulder, and say it's okay, because they trust you and they believe that you can do it. So there's kind of those two extremes, I think. Most people suffer on the first of it of not calling, so they don't want to bother, but there are also occasionally folks who just lack confidence and need to build that confidence that they can do these cases.
Thank you very much for that, Morgan.
All right, we've got two questions in the chat and they're fairly similar. How can a junior faculty member balance between developing your own skill set and that of the residents? So I have, again, one person's opinion. I have very strong opinions about this. So, and I come at this from a surgical education perspective. When I was a faculty member interviewing at Michigan, Mike Mulholland said to me, so how are you going to handle moving to the left side of the table? Because you're moving to the left side of the table. And I, that was such a great question that I now appreciate. People have this idea, and we've actually studied this pretty rigorously and have some great data to support what I'm about to say. But people have had this idea of, gosh, you can't teach somebody else until you get through your own learning curve. I would say if you are going to be an academic surgeon, you need to learn how to do these operations well from the left side of the table. And people don't magically, if they spend 5 years operating on their own, they're not able to pivot back to teaching residents. And we have young and older faculty, junior and senior faculty, who we've looked at this, who give more or less autonomy regardless of how far they are out. And the outcomes are the same for patients. So I firmly believe that if you're going to be an academic surgeon, you have to learn how to operate with fellows and residents. You have to do that safely. You have to have excellent outcomes. That means you stand on the left side of the table. Now, occasionally you might change sides. And I was operating with one of my junior partners the other day, went over to help him with a case at the VA, and I was like, I can't stand on the right side. I don't know how everything looks from over here anymore. So, and he laughed because he just come out of fellowship. He's like, great, because I can understand the anatomy much better from the right side of the table. So we switched spots and moved through this one step and then switched back, and then he kept things going.
So I do think that you have to learn how to progress with a trainee safely. And I don't think not doing that for 5 years and then expecting you're going to suddenly switch over and be able to teach somebody else, it's actually the opposite is what we found in our research. You can't, because now you've learned how to do these cases without trainees, and that's what you're comfortable with.
Great. Thank you so much, Dr. Mentor. It was a great talk.
Thank you so much for the invitation. I will hang on as long as I can and hear the other talks.
Yeah, thank you, Dr. Minter. I think we're off to a good start. So next up, excuse me, is Greg Wilson from University of Cincinnati. Greg is an assistant professor. I had the pleasure of making the interview rounds with Greg a few years ago, and he's a good guy, and we've had a lot of talks about how to do exactly what he's going to talk about today. So Greg did his residency at Cincinnati and then went to UPMC for fellowship, where he did a lot on the robot with the group there, and then came back to Cincinnati, where he had trained as a staff and has had some experience with his topic today, which is I didn't do this in training, tips on integrating new technology or approaches into your practice as an early career HPB surgeon. So Greg, take it away.
Well, thanks, Tim. I really appreciate that introduction, and I'd like to thank Dr. D'Angelica and the Society for the opportunity to be here to talk to you guys as a group today. Tim, can you just confirm you can hear me and see my slides okay?
Yep, good to go.
Excellent, excellent. So, I have no financial disclosures, and I think this is really important, especially when we're talking about new technology and new approaches. You look at the number of studies that have shown positive effect on some of these things that are funded by some of the companies that are producing the technology. And so I have no disclosures. I have no relationship with any of these companies. I do perform both robotic and laparoscopic HPB cases. I'm biased in that I do prefer a robotic approach for pancreas surgery, while I prefer a laparoscopic approach for liver. And we can talk about that a little bit later. Additionally, as the title is a little bit of a misnomer, because I did train at a fellowship with a pretty rigorous robotic training structure. I did not do much in residency, but I did do a lot, took advantage of it during fellowship so that I could incorporate that in my practice as an attending. Now, I think any talk regarding new technology approaches, we kind of need to understand what is the landscape a little bit. And just 2 recent studies demonstrating the number of robotic cases in both surgical oncology and HPB surgery has been on the rise, and has been on the rise for the past 10 years and, continues to rise. And, anytime we're talking about innovation or new technology, there's going to be a bell curve in how this technology is really introduced. And so you, as the junior faculty or trainee who's getting ready to enter in this, you need to kind of figure out where you are in this curve. Now, if you look at, social media, you would think we're in a late majority for some of this stuff. But I'll tell you, just on those previous numbers, we're actually probably a little bit over here. Now, I would love to encourage all of you to incorporate some of these technologies into your practice, and I'm passionate about this, and I think it's a great thing for our patients. But my opinion as a junior faculty is pretty minimal. But I do want to provide an opinion that might have a little more impact for you. And this is a quote that I want to read to you because I think it's important. There's some argument, I guess, still from our prior speaker about whether this operation should or can be done minimally invasively. To the young people in the audience, learn how to do them minimally invasively, or 10 years from now, you're not going to be doing pancreatic odontectomies. Now, I certainly didn't say that to a group of people, but Dr. Cameron did in his address at the IHPBA in 2018. The man who's done more, pancreatic odontectomies than anybody, saying something like that is pretty profound. And so I think when you hear something like that, you really need to consider that, your ways and how you're going to incorporate some of these newer approaches into the operations you're going to be doing. Now, sadly, the reality of all this is very different than what mainstream social media would like to tell you. A recent survey of HPB graduates from training programs in North America identified that robotic surgery is one of their main perceived deficiencies, and that the majority of fellows had either no or unstructured access to robotic training. And so now that makes it extremely difficult for you as a young faculty coming into practice to incorporate this into your skill set. And so how do you do this? Well, you need the physical skills initially. And I break this down really into two different skill set. And we're going to focus mostly on robotic surgery here with this. You need the technical skill set, and then you also need the know-how for the procedure specifics, whether you're talking about a robotic Whipple, laparoscopic liver resection, or anything. There are some specifics to that procedure that you need to know and understand before you can safely do that. The technical skill set, this one can be done pretty much on your own time and your own turf, between the simulation centers, the inanimate objects, you can work on developing your robotic skill set. There is something to be said about, developing your robotic skill set, and that's different than most of the other surgery you've done. You have no haptic feedback. You need to learn to develop that with your eyesight and using the camera to see some of the things. Additionally, you're controlling 3 arms, actually 4 arms if you count the camera instead of just 2. So you have to take all that into account. You can develop all these skills without ever even doing anything in the patient. Additionally, one thing that I think is critical, and again, I have no financial relationship with any of the companies presented here, but this is a pancreaticojejunostomy kit of a silicone-based biotissue. You can actually order these. I order these routinely, and I do these, as you can see in this next picture, with my residents. We have Wednesday evening sessions where we go up and we will do a PJ anastomosis. That's my intern right there who's shown us how interns can break 5-0 Prolink quite nicely on the robot. It's actually very easy to do. But you can use these biotissues to develop this skill set and really hone your robotic skills so that you can start to feel safe incorporating this into clinical practice. The next one is procedural specifics. And a lot of this starts with some of the videos that you can find and look at for some of these procedures. Now, I do have a word of caution because a lot of these videos you find are going to be edited, or they're going to be focused on the anatomy and the tissue that's being moved. This is just a picture from a recent robotic Whipple I did. You can see what's being done there. We're working on the uncinate dissection here. But this picture in this view tells you absolutely nothing about how to do this. You really would need to watch videos in real time and unedited, because you need to figure out how did I set up the retraction so that I can actually get this view to safely do this part of the dissection. And that's really, really important. Sadly, most videos are not that way, and you really want to look at these things and get some videos that are unedited so you can watch them in real time. Once you've kind of developed some of these procedural specifics, looking at videos and other sources, you also need to consider, is a course with hands-on experience something that you need to take it to the next level? There's a number of them that are available. You can search the internet to find what might work for you and would help you get to the next step. Now, the next part in all this is you really need to develop your team. And I'm not necessarily talking about the team within the operating room, because that's extremely important as well. And that's important for any of your cases. But you really need your team structure around you that's going to support you through this process. I came back to University of Cincinnati, an institution that had never done a robotic Whipple in its history. And, one of my biggest supporters was this guy at the top of the picture here, Sai Ahmad. Now, I could tell you he has no desire in the world to do a robotic Whipple. But without his support, I could not do that. And so you need the senior partner who's going to support you through any of these endeavors to incorporate some of this new technology. The next thing you really need is kind of a partner in crime. And this is critically important because some of these cases, there are difficult portions, the uncinate dissection during Whipple operation. It is nice to have another set of eyes and hands available to help you during these portions of the case. Samir Patel is one of my partners, has scrubbed numerous cases with me during these. We help each other out during any MIS approach. We're there for each other. When the case is scheduled, it gets put on my schedule and his schedule, just so he knows or I know to be around so that we can help each other. Because that way we get better, we do it safely, we make sure we're not taking any risks for the patient, and we incorporate it. The last one is obviously, this outside consultants. You need the experts in the field, whether they're senior or a co-fellow of mine in Alessandro Panicia, people that you can really kind of talk to kind of iron out some of the difficulties. What was difficult? Or are there any tips or tricks on how to do this better? Next, anytime you're looking to implement new innovation, new technology, patient selection is absolutely critical. Just 2 comments here for both these procedures that I think are extremely important for anybody considering this for a robotic Whipple. Everyone thinks that the non-cancerous or, very small tumors are probably the best cases. And from a dissection standpoint, they might be. But from a reconstruction standpoint, they're actually the hardest cases. And so you really want to have a case that's an early cancer that has the classic double duct sign, dilated biliary and pancreatic ducts. It allows one, the dissection is a little bit easier, but you also have an easier reconstruction for patients. No vascular involvement, especially early on. And one of the things that I found tough early on doing some of these cases was these low uncinate tumors. It really makes that uncinate dissection quite difficult. From a liver standpoint, the only comment I'll make is that you do not want to, have one of your first MIS liver resections be a segment 8 or segment 7 resection. There's difficulty scores for a reason. Know these, incorporate these, think this out as you incorporate this into your practice. You also need to have realistic expectations. The patient comes first here for all this. Your primary objectives need to be clear. Your job is to provide an oncologic operation for the patient and get the patient through the operation into recovery and back to their life. Implementation of new technology is not the endpoint. It's merely a means to the end. I'll make a brief comment on learning curves. We're not going to talk much about it, but you do need to understand these. Learning curves are there for a reason. Early on, you may be in your learning curve for the open case, let alone an MIS approach. You need to understand where you are and, understand your boundaries and how far you really want to push things. And as Dr. Minter mentioned earlier, have limits. If you're failing to progress a case, don't be afraid to convert, which leads me to my final point. You always need to have a backup plan for conversion. This really is a 2-surgeon process, especially if it's an urgent conversion. You want to maintain a controlled environment throughout of it. You need to have someone available to release robotic arms once control's obtained and you open. And another option that you can always is consider a hand port. This is a good option if you simply need to feel or get hand pressure on something to get control of something that's bleeding that you can't quite see. Conversion is not a failure for any of these operations, but failure to plan for one certainly is. And so, my final thoughts is I do want to encourage everyone to consider implementing this, new technology and approaches in their practice. This is going to be an ongoing thing throughout all of our careers. You really need to develop your skill set and support team, and you want to focus on safe implementation. Have a plan, have a backup plan, and remember what's important. The patient is important. New technology is really only a means to an end. I'll end there. Thank you.
Thank you very much, Greg, for that excellent insight, excellent talk. I really appreciate those pearls. They really hit them spot on. We're going to save our questions for the rest of our speakers for the end in the interest of time. And then so feel free to place any questions you have in the chat. So without further ado, we'll move on with our next speaker, Dr. Qingwei Zhang. Dr. Qingwei Zhang is the Associate Professor of Surgical Oncology and HPB Surgery here at MD Anderson Cancer Center in Houston. Dr. Zhang is consistently recognized for both his leadership and devotion to the education and mentorship of trainees, and I can attest to you personally of junior surgeons here at MD Anderson, as well as others who have crossed his path along the way and throughout his career. He's the program director of our HPB fellowship here and has truly taught most of us how to provide exemplary care for our patients. So today he'll be talking about exactly that, how to safely care for complex HPB surgical patients during your early career. Thank you very much, Dr. Zhang.
Thanks, Tim. And thanks to the HPA for this opportunity. I wish I could blurt out all I've learned from mistakes on my own, but I'll try to tone it down to 10 minutes of mistakes. Here are my disclosures, none related to this talk. Let me start with a disclaimer, a lot like Dr. Minter. There's more than one path to success. And I do have a slight academic bias in my thoughts. I've had 2 jobs and 9 years out of fellowship. And success is truly defined differently for different people. To me personally, it's just reaching whatever inner excellence you can reach inside, your own potential, we can call it, that we have inside us that we can balance great patient outcomes with your personal life goals. So that's really trying to reach that balance is really what will probably make you happy. So I'm glad that Greg talked about learning curve. I think the main point from all these papers people publish it for is that there is, unfortunately, no exact number. The number depends on the case you're taking on, the surgeon, that's you, and your help. Don't be frustrated if cases take longer at first than what you remember in fellowship. Don't forget the person on the other side is not you, and the person who is the surgeon when you're fellowship is a person who's been in practice for a long time. Time is not what matters, just patient outcomes. Choose carefully in the early part of your learning curve. Sometimes you have no choice. These referrals don't come to you in some kind of stepwise fashion, but you should involve senior partners, at least similar level partners with capable hands and minds, just like Greg just talked about with Samir. Adapt what you have learned in fellowship to teaching trainees, as Dr. Mentor mentioned. It may involve more hands-on and less autonomy in certain parts of the case at the beginning than what you expected, and that's okay. Patients come first, but really learn to work with the trainees. I want to talk about this term coward versus cowboy. There's 6 points I want to make here. Safety is first. Your initial reputation depends on it, and your initial reputation will stay with you potentially forever. That's not to scare you, but in fact, just to remind you of how important it is. You look at our plastic surgery colleagues, they have a case log they have to keep for 1 year. I personally am trying to push for that on HPB, where we keep a case log and then ask for certification, because then we would actually be more careful in what we do in our first year rather than trying to do an ALPS as our second case. Say no to extreme or crazy cases you remember from fellowship, and refer them to more experienced surgeons. Swallow your pride for a year. Don't let anyone intimidate you into an operation just because you came from wherever you came from. Cowboys are not viewed in a good light, and safe surgeons will never be called a coward. Don't worry, you'll be called a safe surgeon and a good surgeon. There's a term that Tom Aloya told me about, is a graveyard. And I know this sounds kind of morbid, but every surgeon has a graveyard that they take with them their whole life. You haven't done 1,000 cases, so your denominator is quite small. So keep that in mind with your case selection and be careful. And finally, find that balance between confidence and humility. You need that confidence Dr. Mintzer was talking about moving along through the case, but the humility to know what you can take on. Let me talk about safety a little bit more and why I think that's our #1 priority in the United States. The 90-day mortality for Whipple is more than 7% and more than 10 to 15% for elderly patients. The 90-day mortality for major hepatectomy is 5%. You're like, no, I have not seen that. Well, I'm not talking about you. I'm talking about in the country, and that's what we have to push for as an HPBA. Hilar cholangio, there's a paper that came out that benchmarked 13% death rate as okay. Ouch. So these are the things that we need to work on. So in my opinion, the key to success is not more cool photos on social media, I know it's a little sarcastic, of your last BP car or your last ALPS, but an empty graveyard and more patients going home to their families. I would submit we should all try to put photos of our survivors on social media rather than cool photos. Here's a little business advice. You can build up a better word-of-mouth referral base with living patients. Patient-centric outcomes. I think everybody should try to keep a registry. And I totally get it. When you're an assistant professor, I didn't have any money in my first job, but at least try to keep something perspective so you can kind of keep an eye on how things are going, what you're doing. It's really hard to anecdotally evaluate yourself. Reflect on your own complications quarterly and yearly and try to make goals for the next year. Have these yearly goals for improvement in complications, length of stay, readmissions, mortality rate. Nowadays, we have the Vizient rankings, as you know, for hospitals. So take a look at that so you can try to make an improvement. And I'm a big sports fan, and professional athletes, of course, nowadays review their batting average, ERA, shooting percentage. They review their videos. And one thing I want to remind you of as an HPB surgeon is that you're even more than a professional athlete because you're operating on human beings. So if they're doing that to hit a ball, I think we can certainly do that to take care of people. Surgery is a team sport. Certainly there are a few individuals out there who seem to be able to succeed alone, but that's rare and unnecessarily difficult. Share your victories as a group. Then your tough times will not be suffered alone. You can have mentors separately for clinical, education, research, career. You can have sponsors who help you with committees across the country. They don't necessarily have to be in your institution. Clinically, develop a team of go-to medical oncologists, radiation oncologists, IR, GI, people who have similar philosophies in the hands-on multidisciplinary care that we as HPB surgeons really want to do. That way, you can help them and they can help you. Finally, regarding team sport, say the words thank you in the person's name. Those are the 3 highest return on investment words in your vocabulary. Use evidence and evolve. Read and keep up to date on iterative changes in patient care. And these are just some obvious things in the last 10 years, right? Enhanced recovery, drain management, bioleak tests. Hopefully you're not practicing the way you were in fellowship 5 years down the line or 10 years down the line. You've made some iterative changes in your practice. I'm not saying you're going to revamp everything, right? But I'm saying that big wins can come from these small improvements in the daily practice of your career. Don't end up being a dinosaur. The game is won before the coin toss. The preparation is the key to reducing anxiety. As Dr. D'Angelica said at the beginning of the introduction, we all have this anxiety as we start our career. And the greatest anxiety probably is how to deal with these cases, right? And how can you deal with it? By preparation. And you've seen on social media some of the drawings by our fellows, and these are just standard pictures that we draw every week in preparation. It's not an art contest, although it seems like it's pretty awesome how well they've drawn. But really, it's more to understand the venous anatomy, as Matt Katz has taught us. That's the roadmap to surgery. The parenchyma is just what's going to go away with the venous anatomy. This will help you prevent anatomic errors and misinterpretation. Don't preview your intraoperative GPS. This is what I mean. If I'm asked to drive from here to Dallas, I'm not going to just jump in my car and turn on the GPS and just start driving, right? You're not going to do that in the operating room. You would at least preview the map and get a general sense that at least you're driving north and which highways you're going to be driving on. So do that with surgery as well. If you think about what professional athletes talk about in their post-game interviews, they always talk about how they imagine how the game would go. And think, well, how could you do that? You can't really imagine it perfectly. Of course not. But you can at least imagine a way you would want it to go. And that's what you should do as a surgeon. So improve your efficiency so that you can reduce your total OR time. Again, it's not a race or anything like that, but it will improve your efficiency to plan ahead. It'll help with communication and teaching with your residents and fellows, so there's not a play-by-play where you're trying to get them to read your mind what the next step is. They know what the next step is because you've already thought about it and talked about it. And ultimately, it leads to better safety. Post-game evaluation is key. The fancy surgical education term, of course, is debriefing. I would ask you to record your MIS and open operations just like Greg was talking about, and review them. Formalize your thoughts with your assistant or trainee, what went well, what could have gone better. But the key is to look in the mirror. You have to watch these unedited videos, as painful as they may be. These are freeze frames of my fellow's left hand, and this is actually a freeze frame of a video that on open surgery. So this is, obviously MIS operations are very easy to record, but open surgery you can record as well pretty easily. And in this one, the fellow took about 30 seconds, 45 seconds to kind of get an idea of how much length we had on the portal vein and SMB to see whether we need an interposition graft or we just do an end-to-end. And by letting them play around and kind of feel how much tension there is and all that, it gives them a better sense. And then also by reviewing it later, they have a better idea in the future of what they need to do. Also, of course, you can review your suturing technique, because the truth is, in fellowship, you're not going to probably do 20 portal vein resections, right? You only get to do a few. So each one you should extract the maximum value, and the post-game video review is the way to do it, and even for open surgery. This is a paper, a piece of paper I came up with in fellowship that Jason Fleming asked me to do, because he always asked me, okay, how much time should I be allowed to give you to do certain parts of the operation? And we all have a gestalt, and honestly, I didn't know. So I came up with these steps from what Dr. Evans came up with a long time ago, right? The 6 steps of a Whipple, right? And now I've changed it up, so it also includes what kind of material we use, what kind of energy device. So it's useful when your personal scrub tech isn't there that day. The CRNAs even use it now so that they know what step of the operation we're doing. And so what we do is during the case, we'll call out, hey, I'm on step 3, I'm on step 4. This allows you to analyze with your video how long certain steps take. And this helps with the efficiency part that Dr. Minter was talking about at the very beginning, where you should see, hopefully in an easy case, you're going to get the specimen out in the AM. If it's a difficult case, it may take into the PM. Again, it's not a race, or I'm not implying that in any way, but it helps you analyze. Like, for example, this case took only about an hour for step 6, or the retroperitoneal dissection and all that. And the PJ was pretty efficient at 35 minutes. And an inefficient PJ, I know, now is about 45 to 50 minutes. It's usually because we get our strings crossed up, or we have to cut out a suture, things like that. And these are things you learn by actually analyzing your outcomes by video review. All right, you want to hear how to reduce complications, right? I don't have any magic answers, but preparation is really the key. You should learn and pay attention to M&M, for example. You don't want to repeat what others have done, although we're all bound to do that. Patient optimization is the standard. Even with surgery up front, you have a few weeks to get them optimized, at least do a little bit of prehab and exercise. Surgeon preparation. This is what was spoken about earlier, in that your bigger cases, definitely make sure your partner is around, right? As Greg was talking about earlier, you make sure that Samir has the case posted on his schedule too. Do not be looking up in the OR wondering where your partner is, and all of them are out of town. Of course, during COVID, they're all in town, but in case they're all out of town, you're going to be in big trouble, right? Prepare the anesthesia team regarding realistic blood loss expectations and extensive surgery. Of course, you're going to try to lie to them and say, this is no blood loss, everything's going to be perfect. And eventually they'll no longer believe you. So be very honest with them about what you expect. Vein resection or no vein resection, major or minor hepatectomy is probably easiest for them to understand. Okay, so how do you avoid excessive blood loss and unnecessary transfusions? I know this is a topic on Twitter last night. So how do you avoid that instead of blaming anesthesia? Okay, this is the way I think about it. You all have an acceptable aliquot of blood that you can lose. That's different for a person with a hemoglobin of 12 versus a person with a hemoglobin of 9.5 after neoadjuvant therapy. Use that blood sparingly and be very careful. Once you reach a point where you think that aliquot is nearly gone, you may need to call a partner to get through a difficult part of the operation instead of plowing ahead through the portal vein and getting to the point where the blood loss gets to a point where it's tipping over that they have to give a transfusion and you're starting to blame anesthesia, when ultimately you could have prevented that had you got a partner for about 15 to 30 minutes to help with the difficult part of surgery. Finally, I want to say that okay is not okay. You don't get a chance to come back to the operating room to redo it. Cut out your sutures if you need to and redo the anastomosis. I don't care how long it takes and how painful it is and how you regret it, but you have to do it. You will only regret it if you don't. The surgeon technique is one thing that's not accounted for in all these multivariate analyses and calculators that have been published, which are useful on a population scale, but less useful on an individual scale. Your surgical technique is the most dominant factor, the greatest odds ratio that's in no multivariate analysis. Finally, be the surgeon who asks for help ahead of time and not after, as mentioned before. That is the true sign of maturity, asking for it ahead of time. Okay, complications will happen. What now? Honesty and transparency. These are key terms that Matt Katz has put in our heads. That's the key to dealing with your complications. Involve your partners, trainees, APPs, your whole team as soon as you suspect a complication. Also, you should have judicious management. No knee-jerk reactions. You don't necessarily have to rush and do a take-back or a completion pancreatectomy for a fistula where the mortality rate from that itself is like 50%. Be very careful about how you manage small mistakes and not turn them into medium and medium into ginormous mistakes. Prevent the dominoes from falling. Be transparent with the patient, of course, and be willing to share your experiences post hoc so that others may learn as well. I think what was mentioned earlier before too, we have to be resilient, bounce back, and continue to help others. Complications will be part of our lives. How we deal with them is what defines us. During the workup of a treatment, and treatment of a complication even, in that current moment in time, you're still taking care of other patients. So you do have to compartmentalize a little bit and focus on treating the concurrent patients as well. They deserve your attention. Life balance. HPB is very exciting, but it has turned off some trainees because of the presumed huge amount of complications and the constant hypercortisolism, I call it, and tachycardia. I mean, how can you sleep well and truly enjoy life outside of surgery? How can you have nights and weekends go coach Little League, right? Well, you have to mitigate the risk of complications. That really is true. There's no getting around that. And there are different ways to do that you'll learn in fellowship. But you must also learn to trust others. You don't blindly trust them without helping them, but trusting them. How do you do that? You empower them with your risk stratified protocols so they don't read your mind on how to take care of patients. You communicate honestly about any kind of concerns. And of course, you round for your partners. By rounding for your partners, you'll learn their tendencies and they'll learn yours. And soon you'll be an interchangeable team, not feel like you have to take on the world by yourself. In summary, the case complexity of our field is often what draws us initially to it. But the enjoyment of seeing these great patient outcomes is what keeps us in it. And learning how to take care of complications is key. Managing that inherent complexity requires purposeful surgical planning, iterative self-analysis for constant improvement, open-mindedness for advice and help, transparency, honesty, and even-keel decisions for any complications that do come up, and trust and empowerment of your team to allow a life balance for yourself and your family. Thank you.
Thank you very much, Dr. Zong, for that true masterclass. I was waiting for you to say what you always told me, which is you can't ERAS your way out of poor surgery. So moving on to our next section here, we're going to have some excellent comments and experiences from two sets of experiences as junior surgeons may enter in their early practice. So first, we're going to hear from Dr. Kelly LaFaro, who is an assistant professor of surgery, both a surgical oncologist and HPB surgeon at Johns Hopkins. She is a superstar junior surgeon who joined a well-established and obviously well-renowned HPB surgical practice in Baltimore. And we're fortunate that she's able to share her experience here with us today and provide us some guidance, as well as some pearls that she's gleaned along the way in joining such a practice as a new partner. So without further ado, thank you so much, Kelly, for your time.
Great, thanks, Tim. Thanks, Dr. D'Angelica and the AHPBA and the Young Surgeons Committee for letting me talk today. All right. I have no disclosures other than I'm starting my third year of practice and I'm still figuring this out, but I'm going to talk today kind of about I made a top 10 list of things I wish I knew coming into practice. So I don't have to tell everyone this. We've all come a long way. We've had many years of training, at least 5 years of residency. Most of us did research, 2 years of fellowship, and finally, an exhausting and anxiety-provoking job search. You finally landed, your academic HPB job, and now what? Often, these jobs are in places that you did not train. So you're going to a new city, you have a new house or apartment, a new hospital, an entirely new OR team, new residents, and new partners. And this can be really anxiety-provoking. So top 10 ways to contribute. These are things, like I said, that I wish I had heard coming into practice. We'll go through each of them separately, but number one is identifying expectations, understanding metrics of success, setting your goals and agenda, finding and developing your niche, learning the landscape and politics, identifying barriers and suggesting solutions, observe and assist, asking for permission when necessary, and calling for help, and lastly, enjoying the ride. So first, identifying expectations. I think Dr. Minter talked a lot about this, and I completely agree. Hopefully this was talked about when you were interviewing for your job, but I do think it's really important to sit down and talk about with your direct boss, and as well as the chair of surgery, their vision for your position. And make sure this aligns with your vision. And it's really important to be honest about this, because if you're not happy, obviously, then the job is you're not going to be successful at your job. Like Dr. Minter said, I was hired by one person and I got a call literally the day before I started telling me I had a new boss. And so, it's really important, especially in those circumstances, to sit down and make sure everyone's on the same page. You want to identify the metrics used to define success in your position. A lot of those metrics, as was already talked about, RVU targets, grants, manuscripts, and most academic institutions actually have written down policies about what it takes to become promotable. So at Hopkins, there's the Gold Book. It actually writes out the criteria. So I would ask your mentor, your boss, if this exists for your institution, and it's a nice guide to have. You should keep track of your metrics and check them quarterly if you can, just to have an idea of how you're doing. It's really important to set your goals. Dr. Minter talked about this too. I think 1, 3, and 5-year goals are really important. Also, what's important is to figure out what you need to reach them. Most institutions have courses in grant writing or manuscript writing. There's courses in certain types of research, there's webinars, and it's really important to identify mentors to help you get to your goals. It's also really important to hold yourself accountable. As was talked about earlier, we've kind of been told what to do for our entire career up to this point, and now you're pretty much on your own. Obviously, you have mentors and bosses, but it's really important to hold yourself accountable. And also, it's okay to say no sometimes. I think that we have a culture of saying yes to everything as we go through. Obviously, you want to help out people in your division. You want to help your boss out if something is really important and needed. But there are a lot of also extraneous things, and it's better to say no to something than to deliver late or not to deliver something up to standard. Also, you want to find your niche. So somebody once told me, you know, what are you going to be famous for? In fellowship, Human Fongs all the time. Kelly, what are you going to be famous for? And so I think it's really important to think about that. What is your passion? And learn about it and really become an expert in it. But it's also important to realize what's lacking in your division. Where can you shine? So it may be a certain technology, like Greg talked about, we're bringing robotics to Cincinnati, or an operative technique. There may be an educational void. Also, there may be kind of a lack of unity between the different specialties or leadership positions in societies. It's really important, I think, to find that. And if you're able to capitalize on it, you'll really help your division grow and expand. Learning the landscape. Obviously, this is a very big topic and very broad, but learn everyone's name that you work with. It's a really easy way to show people that you value them. Also learn the politics. Just for example, you know, who does the resections of HCCs? Is it HPB? Is it transplant? Is it surgical oncology? And who does the vascular reconstructions? Do you do them yourself? Is it expected that vascular come in or transplant come in to do these? Also important to learn the referral patterns. Where do the patients come from? Are there specific groups? And really be good to your referring physicians. Make sure you communicate with them. Also, Dr. Minter talked a little bit about this too. I think a lot of the stuff I'm bringing up has been said already, so I do apologize for repeating, but there are always going to be problems and barriers. And what's really important is that you have a solution. So when you go to your boss, it is important to communicate with your boss about any barriers or problems, but bring a solution. And if you can, bring data to support that. And then observe and assist. You know, observe your partners in the OR whenever possible. This was really stressed by Chris Wolfgang. He would always say, I learned something new from every operation I watch. You know, surgery is lifelong learning. I tell my fellows this all the time. You can learn so much just from watching an operation, even if you're not the one doing it. It'll help you grow as a surgeon and also may make you more efficient by learning new techniques. When I started at Hopkins, Jinhee had opened a robotic, a randomized control trial looking at robotic Whipples. I had a lot of robotic experience, but more so in liver and distal pancreatectomies. We had done many Whipples in fellowship. My first robotic Whipple took probably 8 hours. I watched, Jin do probably 20 cases after that, and it cut out, just watching his cases cut hours off of my time. I was able to learn so much just from watching his case. And also, I went into the OR and watched it. I didn't, watch the edited video, which I do stress, because it really is being there and watching the setup and watching the different parts of the case that are helpful, not just, the small portion that he's looking at that time. And then also, this has been talked about a lot, but I can't stress it enough. You really need to plan ahead with your cases. Talk to your partners about decisions on cases to operate, especially ones that are locally advanced or out of the box. And probably more importantly, talk about when not to operate on patients. I think it's really hard to be in a room with a person and tell them that there's nothing you can do for them as an attending, because you're pretty much the last word. And that's really important. Also, review your cases with your group or any other specialty that might possibly be needed in the OR, and plan for a day that they are in town. Just like Greg said, put it on their calendar even, so that they know to be around. And call before it's an emergency. It's better to have somebody come in before you get into massive bleeding than to have your boss have to stand up at M&M and defend you. It's also better for the patient, and obviously that's the most important thing. And enjoy the ride. You're finally there. formalized training is over and this is the rest of your life. So you really need to find a schedule that works for you. It's no longer, oh, I have to just get through 2 more years and then, you know, things will be a little bit better. Make sure you take some vacation and time to yourself every year. It is definitely, you know, can be emotionally draining. We are in a field where there are complications and you're called, you know, you're on call 24/7 for your patients. Take some time for yourself and enjoy. And thank you guys.
All right, thank you very much. That was an excellent talk. We are now going to move on to a similar topic, except we are going to hear about it from the community perspective. We have now Dr. Lee Akuan, who is currently at the University Hospitals in Cleveland Medical Center, but began his career in a community practice in Charlotte, North Carolina. Lee?
Yeah, so thanks to the Junior Surgeons Committee for asking me to give this talk, and Dr. Giangelica for hosting it. Let's get my slides up. You guys see those okay? Okay, so I'm going to talk about you know, tips for establishing successful community practice. This is you know, things that I learned and were taught to me actually you know, at my first job. You know, and sort of just over the past few weeks, we're reflecting on some things. My one disclosure is, as Morgan alluded to, I started my career at Atrium Health at one of our community affiliates. Average January temperature is 49 degrees with about 5 inches of annual snowfall. And last April relocated to Cleveland Medical Center, which is affiliated with Case Western, and it's about 34 degrees and I believe the 54 inches of snow, since it's we've gotten a lot over the past 2 weeks. But anyway, the other thing I would be remiss to do before I go any further is I got to acknowledge that, you know, even getting to this point to give a talk like this, or, you know, build a practice, I had a lot of support. Obviously my wife, I got to, you know, specifically single out Dave Ionity, who was an excellent mentor, you know, for my first job, gave me a lot of advice, sort of real world things that you don't necessarily learn in fellowship or residency. And I've also been the beneficiary of having some good partners and some excellent mentors over the years through training. Just a little bit of background. So Atrium Health, Cabarrus, which when I started was Carolinas Medical Center Northeast, is about 457 bed hospital in Concord, North Carolina. That's where the Charlotte Motor Speedway is. The catchment population is about 3 counties and about a total of 400,000 patients, or 400,000 people. And the surgery coverage there was a mix of private practice, surgical oncology, general surgery, and then there was some hospital faculty that did that focused on bariatrics and acute care surgery. In the 2 years prior to the program expansion, there were a total of 20 index hepatobiliary cases performed at that hospital with a high morbidity and mortality, and most of the referrals were out of system to Duke, UNC, and Wake Forest. And then once we started our program expansion there over the first 3 years, we did 209 index HPV cases with low morbidity and mortality. And I think I would put those numbers up against most major centers, and we weren't just doing the easy stuff. So how did we get to that point? So what are the essential components of an HPV service line? And these are things that when you're entering into practice and if you're looking at a community job, you have to ask. So obviously you need a surgeon and clinical support staff. You need advanced therapeutic endoscopists. You need interventional radiologists. You need an ICU. Ideally, you have a surgical ward dedicated to patient care, and you need a GI-focused medical oncologist or two. But of these things, the foremost important are you need clinical support staff in the office to help you get patients in, schedule tests, procedures, cases, et cetera. You have to have access to advanced therapeutic endoscopists, as several on this have talked about, complications are going to happen. And so it's great if you're the surgeon at this community hospital and you do a Whipple and it goes well, except, we've all had bleeds, we've all had problems, and you need interventional radiologists. You need a salvage mechanism, and additionally, you need ICU. And if you don't have these things in place at that hospital, if you're looking at a community job, that should be a huge red flag, because sure, you can do the cases, but I think the difference in all of the literature that looks at the mortality and outcomes and between academic or non-academic, I think what you're really seeing is a lack of salvage, because the complications are probably going to be fairly similar if you do enough cases, but you have to be able to get the patients out of trouble post-operatively. And then, this I think we all learn at some point, but the 3 A's of success in surgical practice are availability, affability, and ability. And availability is by far the most important ability. You always need to be the path of least resistance. You should always say yes. Any consultant, referring physician, et cetera, that you meet, you have to be, you have to communicate to them, and I'll get to this a little bit more later, that you are always available anytime. And most people are obviously going to respect your time, but you have to demonstrate that you're always happy to answer a question, no matter how mundane, always happy to look at a scan, look at a chart, et cetera. Another key thing, and Kelly LaFaro alluded to this in her talk, but you have to understand referral patterns. So you're at a community hospital starting a practice. There's no sort of history or reputation of that institution performing these complex procedures. You need to understand where the patients are coming from. So as we all know, surgery in general, and obviously HPB surgery is referral dependent. There's a couple of different referral patterns depending on where you go. So at some or a lot of the major academic centers, there are division or section-based referrals. There's a central distribution. Patient needs to see a liver surgeon. It goes to some central scheduler. They look at the schedule. Who's the next available liver surgeon? We're going to assign it to that, that person's clinic. It's almost a plug and play model. And there's also, a high degree of, specific surgeons referrals. I want my patient to see this specific surgeon. And that also happens both in academic, but a lot more in community practice. You're not, community providers are not necessarily referring to a service line. They're referring to a specific surgeon. So you need to be cognizant of that. And then the other thing you need to know about referral patterns is, where are the referrals coming from? So if you sort of break down who, and it's obviously more than this, but if you think about where the referrals coming from. So gastroenterology is going to refer most of the pancreatobiliary disease. And if you have a hepatology group or gastroenterologists who practice hepatology, you'll get some HCC referrals from them. Medical oncology, obviously is going to see the patients with, the bulk of colorectal liver metastases, neuroendocrine liver metastases, other, complex, abdominal sarcomas, et cetera. And that's where that sort of patient flow comes from. Primary care is in the community practice was for me a big source of patient referrals, because patient goes to the ER with abdominal pain. There's some incidental finding. Who do I send the patient to? There's an incidental pancreatic cyst, an incidental liver lesion, an incidental retroperitoneal mass, and then obviously there's going to be inpatient consults. Someone's parent or grandparent showed up to the ER jaundice, they get admitted and they get the, standard workup scan, they have a pancreatic head mass, and they're going to need to call a surgeon. So which surgeon do they call? So the reason you need to understand these referral patterns is because outreach is huge. So one thing I didn't have on that first slide about the key components of an HPB service line is, ideally, the hospital has a liaison who knows these things, knows referral patterns, knows the affiliated medical groups, GI groups, primary care providers, and takes you around to meet these people when you're starting practice, because you want to meet everybody at least once. And it can get, through my own experience, it can get pretty boring, driving to different practice locations, driving all over a state or a catchment area. Especially in North Carolina, it was pretty rural. There was some pretty boring drives on back roads, but you have to meet all of these physicians and make a good impression. And obviously it's COVID now, but I still think that when possible, when you're doing these outreach meetings, it's most effective in person. I had the opportunity to mentor two of Mike Beckman and Mike Dreger, who were hired to sort of build a practice at Cabarrus, and we did all Zoom outreach, and I thought it was pretty ineffective. And there were only a handful of meetings, and there's so many Zoom meetings now. It's hard to motivate GI practice to take a lunch and do a Zoom meeting. So you got to try to get these done in person, and it should be done in 2 stages. So the first stage is the first 6 months. You're not going to be that busy your first 6 months in practice, so you have plenty of time to go out and meet these physicians, introduce yourself, and communicate with them, try to make a good impression, give them your personal contact information, etc. But it's also important to go back later, because when you're fresh out of fellowship, you're meeting a private GI doc who's been in practice for 25 years, who probably has been referring his patients to somebody else outside your system, and he's looking at you as you're a young person who knows nothing, right? So how do you build confidence in that? And it just takes time. And once you've established yourself a little bit, you go back and you meet these people again. And now, instead of talking about what you're interested in, what you want to be doing, you can actually tell them what you've been doing and that you've built it up to X, and you're doing these types of cases now, and you have good outcomes. And I think that resonates a little bit, certainly with some of the more senior people who may be a little bit more resistant, to referring to younger surgeons fresh out of training. The goals of outreach. You try to keep it simple. Hopefully the person you're meeting does the majority of the talking, but the things you want to sort of accomplish in an outreach meeting is you want to define your areas of expertise, your clinical interest, and your scope of practice. What you want to learn from the physician you're meeting is their typical workflow. What usually happens when you have a patient who went to the ER and was found to have a pancreatic mass? Like, who do you send that patient to? How do you work that patient up? Who do you typically send them to if they need a surgical consultation, if it's out of system? And then you also want to know what can be improved. Like, what have you had a trouble getting the patient into this office, or have you had trouble in getting a referral in and this patient being contacted in timely fashion? And then you always want to try to meet the office referral coordinator. Introduce yourself, give them your contact information, because at the end of the day, the private practice person seeing 25 patients in a day refer 5 patients to surgery. But if you make some kind of a personal connection with that referral coordinator, unless he or she's being specified on who to refer the patient to, if you make a good impression, they say, well, I'm going to send that one to that surgeon I just met the other day. They seem like a good person. And then, as I alluded to before, when you're meeting these physicians, you want to communicate that you are the path of least resistance. Communicate the programmatic goals, what you hope to build in your practice. Always communicate that you're available to answer any questions, and give that person the best way to be contacted, whether it's cell phone, text message, email, paging system. And then, the sort of the last bit of advice, that I learned, and I think this is applicable pretty much anywhere, but certainly if you're starting a new service line or a new practice, you want to identify or create an OR team. You want to have a couple of scrub techs and a couple of circulators that want to be there. They have to be interested, and they need to be involved in all of the cases so that they learn the routines. You want to make sure that the OR has the proper equipment. So hopefully ahead of time, when you're going through, the recruitment process, if you're going to sign, if you sign that contract, they're bringing you on board, want to make sure that they get you the correct instruments, the correct retractors that you use. Intraoperative ultrasound is essential. A lot of community hospitals are not going to have that technology. You want to have updated technology. If you're going to be doing any kind of ablation, you want to have at least one ablation platform. But those things need to be in place, because if you don't have those components, it's going to be hard to do the cases. And then go slowly. I think, one thing I really benefited from my first 6 months was I had privileges at the main hospital as well as the community hospital. It was very inconvenient to drive an extra 45 minutes to get down to Charlotte and do a Whipple and then have the patient in the hospital, for 5 to 10 days and going down there to round on them. But you want to really perform the major cases, especially if you're going to a hospital that's not used to doing these complex operations. You really want to do the major cases down there for the first 6 months. You can do wedge resections, straightforward distal pancreatectomies. Obviously complications can always happen after any case, but the less technically demanding cases are a good introduction for the OR staff, especially if they're new at this, to your typical case workflow, your instruments, your retractors, and without having the stress of, it might get into a lot of trouble here, or a major postoperative complication. Regardless of your training, whether you went to a super MIS heavy program or, always choose the safest approach. So even if you know how to do a robotic Whipple out of fellowship, that's probably not the case you should be doing early on at in practice, certainly in a community setting where you're a little bit more on your own. And obviously, you should always have your senior partners, or if they're not immediately available, there's probably going to be some experienced general surgeons at your hospital, and make sure they're available to help. This was mentioned, but when you first start, obviously your denominator is low. So any complication, now you have a high complication rate, high morbidity, mortality rate. As we all know, the OR is a very, very small world. People talk. So another reason you want to do those major cases as you're going through some of your initial learning curve, your initial growing pains that we all experience. You don't want to get the reputation that your cases are sort of a flail. You're asking for a lot of different things because you're not really sure how you like to do a case yet. You're still learning your own way. And if you can sort of hide some of that from the staff you're going to be working with the majority of time once you're really going, you can avoid some of that. And also, it's just, I think, at the initial part of your practice, it's just the safest thing for the patient. And then, another, probably the last take-home point is that you have to be really, really patient. So it takes 12 to 18 months to get established and to change any kind of referral patterns. Obviously, you're not trying to cannibalize a partner or something like that. But again, when you're in a situation where most of the referrals are out of your system and you're trying to now capture those referrals and those patients and grow a practice, you have to be patient. It's not going to happen in a week. Rome wasn't built in a day. And then the other concept, and this is one that Dave Iannitti, would always reassure me when I was chomping at the bit, was just be patient. It's surgical Darwinism. If you are a good surgeon, you do a good job, the word will eventually get out, and it will be survival of the fittest, and you'll change those referral patterns. So think that's all I have.
All right, thanks, Lee. That was a great talk. We are running up on the 90 minutes, so we're probably going to close it out here. But I want to thank everybody, all our speakers, obviously. Those were great talks. Thank everybody who participated. I do want to make a quick mention. There will be some announcements coming out about this, but at the IHPBA meeting, there will be on Saturday the 2nd, there will be a networking breakfast sponsored by the Early Career Group from the IHPBA. And so we're hoping to have a strong AHPBA presence there. And obviously encourage anybody that attended this or anybody that's involved in the Early Career Group to come to that. But I think we'll probably close it out for this evening. We want to be respectful of everyone's time. So we really appreciate all the talks. Those were great. And we hope to see everybody in New York and continue the conversation there. Thanks, everybody, and have a great night.